Hello, this is Dr. Bhaumik. Uh, Welcome to my YouTube lecture series. Those who are following me by now know my qualification. I'm ex-professor of pediatrics, University of South Alabama College of Medicine, and chief of division of pediatric endocrinology, and also retired colonel from United States Air Force. The lecture I am going to give you today is very practical, and this was requested by one of my viewers. And this is a very good request, and I am going to oblige that. So, the lecture I am going to talk to you about the polycystic ovarian disease and functional adrenal hyperandrogenemia. As you know, that as a pediatrician also, and pediatric endocrinologist, even OB/GYN people have also seen this. With the increase of obesity, is one of the factor increase of the obesity, and the incidence of polycystic ovarian disease or hyperandrogenemia is about 5 to 10% from the age 12 to 20, depending upon the series that you are reading. However, I'm going to discuss very practical part. Keep just if thing that you really need to know. Not going to discuss too much about the androgen physiology. And with that thought, let's go and proceed with a lecture. And again, I have introduced myself, so there is no point of wasting time there. So my goal here today is to discuss the practicality, the practical part of androgen physiology, not going too much in the biochemistry, however, and discuss the hirsutism and androgen and their relation and the role that androgen plays for this condition. I'm going to discuss the practical aspect of the polycystic ovarian disease or syndrome and how to make the diagnosis and what is the most critical laboratory finding for this condition. So, first thing that will happen if you are seeing a patient with questionable polycystic ovarian disease, then first thing with the result or first thing with androgen excess, one is going to see the acne. Acne is the most common manifestation because, as I will tell you later, the pilosebaceous unit is very sensitive, is the most sensitive to androgen. And many a times in the pediatric clinic, you see the inflammatory acne or the acne which has been called as acne vulgaris. Then before you send them to the dermatologist or even managed by yourself, I think that this statement is pretty appropriate. As they say, think androgen before you prescribing Accutane, because the treatment of these two conditions is completely different. So think about the androgen axis, which is actually easy to rule out, and once you make the diagnosis, whatever may be the cause, you do the appropriate treatment. Before I go a little bit about the discussion of androgen excess, I would like to uh, introduce to you the two very different conditions which present with the excessive hair growth. One is hirsutism and other is hypertrichosis. One is pathological, the other one is benign. So let's talk about the hirsutism. The growth of the hair is just like bare pattern hair growth. The places where the ladies don't have the hair, and this is where the hair will be seen, and they are thick and the coarse. As opposed to the hypertrichosis, which is a vellus hair usually seen in non-sexual area, and they are usually on the extremities, back of the neck, and also in the neck area. And this is not caused by any hormone excess. But if you go back, you might see that this patient may be taking any steroid preparation, but if that is not so, it is familial. There is a family history, and they will say that, oh, there is a lot of hairy people in our family. Okay, so this really does not need to be treated, and this is not a pathological condition as I have mentioned. And here is the sum of the picture that I have taken from the different journals. This has already been published, and you probably have even better picture than what I have shown you here. And here is this is the chin area, under the chin, and here is probably very typical of the teenager. You can see all over, all over. Actually, in case of Caucasian people, it really could, that may not look all black, but this will be like the vellus, looks like vellus here, but this is hirsutism. Okay. All right. So there is a word notation I like you to uh, pay attention, please, because of the fact that the people think that androgens means the excessive uh, balding of the hair. Is sebaceous gland, uh, is there any role that it plays in the sebaceous gland, and what is the role of androgen sensitivity to the different parts of the body? So let's go to that. If you go and you see that this is sebaceous gland or pilous sebaceous unit, as we like to call, is most sensitive. So therefore, acne, production of acne, of different kind of acne, is probably going to be first manifestation. Then come to the sexual hair. This is intermediate. And scalp hair, as opposed to the popular thinking that we start losing hair, a male as they get older and get testosterone deficiency, they lose the hair in the scalp. But this is actually less sensitive area when it comes to the androgen. So this is important to note that androgen production in the female come equally from both ovary and adrenal gland. So if you take the androgen secretion of 100%, then you will see 50% is coming from ovary and 50% from the adrenal gland. And the concentration of androgen is equivalent to the secretion and also peripheral conversion. So both equally contribute secretion from the gland as well as peripheral conversion. And equal contribution of the male hormone, testosterone, directly from the peripheral conversion, as I have mentioned. So half and half. This is probably best diagram I could show you. This is a little bit lots of space. I mean the steps that you are going to show. I'm not going to show you that. I'm just going to explain that androgen synthesis in the ovary. We all know about that. This is the theca cell and this is granulosa cell. The receptor, LH receptor is on theca cell and FSH receptor is on granulosa cell. So in response to the LH receptor, there is, because since it is uh, this hormone is a steroid hormone, it goes through that pathway and start from the cholesterol, then by different cytochrome P11A enzyme, pregnenolone, then 17-hydroxypregnenolone and dehydroepiandrosterone, and then androstenedione. Now once they produce androstenedione, and as I will show you in the next slide that very similar pathway is an adrenal gland as well. Now androsterone goes to the granulosa cell. And again, this is FSH receptor is on granulosa cell. And so this androsterone then cytochrome P19 enzyme that converted from the androgen to estrone, and that with the 70 beta hydroxy dehydrogenase 1 become estradiol. So therefore it is a concert of both theca cell and granulosa cell to produce the adequate amount of estrogen. So it comes from the cholesterol and then become androstenedione, and this product is then sent to the granulosa cell to form estradiol. So androgen is very important for the formation of estradiol, because this will be a big problem as we talk a little bit about the pathophysiology of polycystic ovarian disease. Now this is the slide I have already put in my talk of congenital adrenal hyperplasia. What is said that this up to this is present both in adrenal gland and ovary. Only difference is there. This is ACTH driven, come from the cholesterol, ACTH, and the gonadal part is derived by FSH-LH. This is the difference. But the thing very same way, they are going in lateral direction, 17-hydroxyprogesterone, dehydroepiandrosterone, and its sulfate form, and it come down to delta 4 androstenedione, then testosterone, and then aromatase 7 activities become estrogen. So, or by the action of 5-hydroxy 5-HT5 alpha reductase enzyme, which convert the testosterone to dihydrotestosterone, which is a very potent androgen. So that path is not seen here, but it say that this path is present in both ovary as well as adrenal gland. So a very important statement here is that if you want to know from where this androgen is coming, the most important test is DHEAS, dehydroepiandrosterone, or its sulfate form. DHEAS is the predominant adrenal androgen, and so if somebody finds too much of dehydroandrosterone, then it is coming from adrenal gland. So adrenarche begins in childhood, mid-childhood. Just think about that. The formation of the breast and the menstruation and the progression of this is FSH, LH, estradiol. Very different pathway. But formation of pubic hair, and that's androgen coming from adrenal gland. So even then, pubic hair comes most of the time after the thelarchy, but the concentration of adrenal androgen slowly and gradually going up until such an event situation where the pubic hair will appear. So these are the two different pathways. In puberty, so formation of the pubic hair is adrenal androgen mostly, and some ovarian androgen as well. But formation of breast tissue and then the growth, these are all from FSH LAs and is coming from the hypothalamus GnRH and then gonadotropin releasing hormone and then gonadotropin hormone. So many people like to call adrenarche as the puberty of the adrenal gland changes and the changes of the adrenal response to the ACTH. Some people believe by the side that there is a quote unquote a adrenarche hormone or factor, and many people like to call adrenarche is the puberty of adrenal gland. So let's talk about the ovarian androgen. The androgen production increased during the puberty, we know that, and as we saw that it's a concert between the theca cell, granulosa cell for the production of androgen and estrogen. So LH stimulate the theca cell to secrete androgen. FSH stimulate the granulosa cell for the aromatase activities to form estradiol from androgen. So androgen is the precursor of estradiol. Insulin and ICF and even the growth hormone may augment its secretion. So look at this androgen and this statement, I like it. Androgen are angel and evil in the ovaries. How it is androgen? How it is angel? Well, if everything goes well, we need androgen for estrogen formation and therefore the progression of the puberty. And however, if there is too much androgen, then it will interfere or hinder the formation of dominant follicle. And that usually take it to the follicular atresia, and they also produce androgen, so there is no formation of dominant follicle. And if there is no dominant follicle, as you know, there will be no evolution. So androgen is great, but it could be a disaster if they are producing too much. So the causes of androgenemia, it could be gonadal androgenemia or adrenal androgenemia, as I have said, and the peripheral androgen production. Okay, and so from the ovary, from adrenal gland, peripheral conversion, as I said, that almost 50% is the peripheral conversion, and then if there is a growth like a tumor, that might produce androgen as well. So functional adrenal hyperandrogenism will be idiopathic. Sometimes we do not know the cause, but we know the congenital adrenal hyperplasia. Even the best treated patient, the suppression of male hormone production or androgen production may not be adequate all the time, so they might present with this acne and the excessive body hair. And the Cushing disease, obviously, it involves if it involves the layer which produces androgen, zona reticularis, and then that androgen production will be manifested by the hyperandrogenemia. So how do we know which is rare? How do one know that this really may be a tumor which is producing too much androgen. And the tumor is usually, it is from ovary or from adrenal as well as. So these are the few points that I have put in the slide. And again, this main reason I have my slides a little bit different from the other, because by just reading this slide, you'll get the adequate information. So you don't have to even go to the book to find what you need to know. So they are clinically is very rapid onset. And there is changes of the voice, and that's because of the high androgen, which is usually not a case of polycystic ovarian disease. And then there is a significant clitoromegaly, genital ambiguity, and obviously physical examination, or ultrasound will show you a abdominal or pelvic mass. So that will suggest a tumoral growth from either adrenal gland or from the ovary. If you want to know biochemically, you will have a very high testosterone level, usually more than 200 in female. But if you have a very high dihydroandrosterone sulfate more than 1000 milligram, that will suggest that it is adrenal carcinoma. So again, I repeat that this hormone is a very good differentiation between whether it is coming from ovary or adrenal gland. If this is astronomically high, it is coming from adrenal gland. Not only so, more than likely it is a carcinoma. And when I talked about the functional adrenal hyperandrogenemia, and when it comes from the ovary, that is a polycystic ovarian disease, and this is the most common form of hyperandrogenemia, not the adrenal or anything else. So this is what we call polycystic ovarian syndrome or polycystic ovarian disease or functional ovarian hyperandrogenemia. And it is the most common cause, and it's seen during puberty. And in classical form, these are the triad. This patient will have excessive hair growth hirsutism, amenorrhea, and obesity. So these are the three combinations that we have read for a long time over that amenorrhea, hirsutism, and obesity is the classic form of polycystic ovarian syndrome. Now, this slide is important to note that in the beginning, as a girl go through the puberty, the diagnosis of polycystic ovarian disease is challenging. The reason it is being challenging that some of the things that we know the combination of polycystic ovarian disease that could be very well physiological. So let's look at that. Menstrual irregularities. We know as a pediatrician that first 1 or 2 years in a normal girl, their menstrual period could be very much irregular. And so in the first 2 years after menarche, diagnosis of polycystic ovarian disease become a little bit difficult, because in polycystic ovarian disease you also have irregular period to no period. Now, as the ovary going through the maturity, the follicular number of the ovary is sometimes is too much, and that might interpreted as some interpreted as there are lots of cysts in the ovary, follicular cyst in the ovary. But that could be the normal for that given person. And then our regular faithful one is the acne. So, and the acne is a very common phenomenon for the girls going through the secondary sexual character development. So acne is the physiological problem in adolescent. So that's why it is important to note that all the symptoms and signs that we have discussed about the ovarian hyperandrogenemia may be confused first 2 years with a regular phenomenon. And so one has to be careful, need to do some diagnostic test and just give little time, so it probably will revert back to normal. So this is a diagnostic challenge in adolescent. And so in adolescent, again, as I have said, the sebaceous unit is very sensitive, but once the sensitivity has occurred, it is more sensitive. But in the beginning, in order to go there, it usually takes several years. And so hyperandrogenemia, blood test women, is the most persistent and most useful diagnostic criteria for adolescent with polycystic ovarian disease. And if there is family history, is also very helpful. And in practice, I have seen that many of the patients who has polycystic ovarian disease, the grandma or mother or their aunt had polycystic ovarian disease. So there is a family history that might help you to direct to the right direction. Now, this supporting clue is called premature adrenarche. Premature adrenarche is usually the only pubic hair formation around the age of 5 or 6. Usually the distribution of hair along the labial border. There is no other sign of puberty. There is no estrogenic effect on vaginal epithelium, and usually these patients are also overweight. And now we know the overweight carry the high risk of insulin resistant and development of type 2 diabetes in adolescent. But not only that, it also makes them vulnerable to develop polycystic ovarian syndrome. And the study has also shown that HGA infant, small for gestation, the girls are also has somewhat higher incidence of polycystic ovarian disease. But this question as a part of the history is helpful. Now, diagnostic approach can be done by the pediatrician or any primary care provider. Is very simple. You don't have to do a whole lot of things. Just you do the testosterone, and the free form will be the best way to go because the testosterone binding globulin might go high, so therefore it may not be, total testosterone may not be as good, but the free testosterone is the best way to go. Also check the dehydroepiandrosterone sulfate form, and again, morning AM sample probably will be the better one. So even the more DICS level, that means it is more coming from adrenal gland, or look at the adrenal problem at that point. Make sure check the FSH, LH, E1 or estrone and prolactin level. Pelvic sonogram will show you some changes that we see in polycystic ovarian disease. And then if one is thinking of adrenal problem, they can do acetase stimulation test or dexamethasone suppression test. When it comes to that, it probably will be a good idea to refer them to a reproductive endocrinologist or a endocrinologist, a pediatric endocrinologist. So, so what will be the most important key laboratory finding? You will have high plasma androgen level to make the diagnosis of polycystic ovarian disease. This will show you the high plasma androgen level, high LH, and less FSH. So LH-FH ratio will be changed more in favor of LH. So high LH-FH ratio and a large ovary, and if you are lucky, you are going to see, you don't have to be lucky, most of the time you may have some, but you will see the cystic ovary. This is a very good sonogram of polycystic ovarian syndrome. This, and this one has been taken from a published literature which is open to everybody, and the radiology book, and they will show you that they are so in the periphery. These are all. This is very classical and looks very convincing at this point. And then second one is not only that the polycystic ovary, this follicular cyst in the ovary has coalescent and producing a big ovarian cyst, bigger ovarian cyst. So it's follicular cyst combined with the big ovarian cyst. So the treatment will be, if the patient is overweight, then weight loss. Intervention and encourage the patient to weight loss. And if they're like a 15, 16 or so, if the family does not object, because sometimes I have seen when they're 15, 16, there are some family object to giving oral contraceptive pill because they think this may have a connotation that the girl is sexually active, but you have to explain to them. So oral contraceptive pill will be a good idea to treat with a insulin sensitizer like metformin. And that's my last statement. And when it comes to the anti-androgen preparation like flutamide, cyproheptadine acetate, spironolactone, and there are many few others are coming every other year, the new one. But I think the most time-honored one and most popular one is the combination therapy of metformin and oral contraceptive pills, and that has worked really good as a part of the treatment of polycystic ovarian disease. So the message that I want to transmit to you is that PCOS is increasingly recognized in adolescent, and since the percentage of obesity in children has also gone up, and it is difficult to diagnose in adolescent, as I have mentioned in one of my slides, that menstrual irregularities and the acne problem is very common in the first 2 years of their pubertal development, and so they kind of throw you off a little bit. However, high index of suspicion and the family history is very important. And not only that, the history of premature menarche, small for gestation, should be included as a part of the questioning in the family history. So, why it is important? It is important because of they accompanied by hyperinsulinism. Some of them might develop type 2 diabetes, and there is a dyslipidemia, and so there is a higher incident of cardiovascular problem in later life. So I like to thank you for listening. So I just want to tell you that first 2 years of puberty, first few years of puberty, it could throw you a little bit off balance, but still there is if you do the lab test, that will differentiate you. And there is another thing that I have got request that to talk to you about the very difficult and distressing part in adolescent or early adult is acne vulgaris. And many of them are not related to the hormone level. If you measure their androgen level, they will be normal. And so, although that's not purely an endocrine topics, but I was a pediatrician for 6 years before I started practicing or got my training and everything to endocrinology area. So as a pediatrician, I can understand the concern. So my next lecture will be the acne vulgaris, where the androgen level is normal. Thank you very much. I wish to see you again in my next talk.